Hello, students. Welcome to this session in which we'll be looking at the EEG and epilepsy. Now, these topics are very clinically oriented. So what I thought I'd do is I would begin with two clinical scenarios, two case studies that allow us to understand what we're talking about when we're talking about epilepsy. Our first case study imagines that you are a physician and you're on call in accident and emergency. A 25-year-old lady presents to you, and the history indicates that she was sitting next to her friend on the sofa when she started plucking her clothes and smacking her lips. When asked what she was doing, she did not reply, but dropped to the floor and started all-over body jerking. When she woke up, she didn't know where she was. There was a small line of blood running from her mouth. So that's our first scenario, and one which is obviously not simply interesting, but would have been very traumatic and very distressing for those who would have been present. Here's another scenario. A 9-year-old boy is brought to your office because of episodic blanking out, something that's been going on for about 6 months. The patient has episodes in which he abruptly stops all activity for about 15 seconds, followed by a rapid return to full consciousness. The patient's eyes are open during the episodes, and he remains motionless with occasional fumbling hand movements. His mother also reports that his performance has dropped off significantly in school, and his teacher complains that he's often not paying attention. Now, this case is very different from the case that we just saw. Everything about the case is different, especially the clinical manifestations. And yet, as you begin to understand what is going on here, we recognize that both have the same underlying situation. In both cases, these persons, the 25-year-old lady and the 9-year-old boy, they are experiencing a seizure. Now, let's define what a seizure is. And before we do that, let us remind ourselves that within the brain, we have neurons. And neurons communicate with each other by firing action potentials. And as you know, action potentials are electrical signals. And so your brain is a hive of electrical activity. And in order for us to function, this electrical activity has to be very well managed. Imagine your house, which is also full of electrical activity. But that electrical activity is managed because the wires find themselves inside of insulation that's controlled by switches, all ensuring that the electricity is directed and managed in a very controlled way. Well, the same thing occurs in a brain, but a seizure is a sudden, uncontrolled electrical disturbance in which there's abnormally excessive synchronous neural activity. And because now this abnormally excessive activity that is no longer controlled, it now manifests in unusual behavior, movements, feelings, and it can even affect your level of consciousness. In other words, a certain part of your brain has started to fire signals in an uncontrolled manner, and therefore that's now going to affect your bodily experience. Let's just look at this video which talks about and describes this in a little bit more detail.
Your brain contains billions of nerve cells, called neurons, that communicate with each other by sending and receiving electrical impulses. A seizure occurs when there is sudden abnormal electrical activity that temporarily interrupts normal brain function. Large groups of neurons fire at the same time, like an electrical storm inside the brain that usually lasts from 30 seconds to 2 minutes. This extra activity can cause changes in behavior, sensation, movements, or awareness. There are two types of seizures. Focal, or partial seizures, happen in just one part of the brain, while generalized seizures seem to occur all over the brain. Symptoms usually vary depending on the type of seizure and can include temporary confusion, staring spells, convulsions, or loss of consciousness. If you think you've had a seizure, talk to your doctor right away for more information.
that was a little video that just rehearsed what we just said and also gave you a little bit of imagery to allow you to appreciate the uncontrolled electrical signaling in the brain that happens when you have a seizure. Well, having defined a seizure, let's talk about what is epilepsy. Whereas a seizure is an event, epilepsy is a disease. And someone who's suffering with epilepsy has some disorder in their brain, which is provoking recurrent seizures. So many people in a lifetime might have one seizure or an occasional seizure. Just because you have a seizure does not mean that you have epilepsy. Epilepsy usually represents the fact that you have recurrent seizures. And one definition says that these seizures must be at least 24 hours apart. Let me also say that we no longer refer to people as being epileptics because that produces a sense of too much identity. And the term we prefer to use now is persons who suffer with or persons who have epilepsy. So what causes epilepsy? Well, there are two important neurotransmitters in the brain there are many important neurotransmitters in the brain. And the brain represents a balance between excitation and inhibition. And the two transmitters that we're talking about are GABA and glutamate. Here you can see a number of cortical neurons that have been stained from the cortex, the cerebral cortex. They've been given a special fluorescent dye that allows them to light up. The glutamatergic neurons are in red, and the GABAergic neurons are in blue. And we can just recognize that most of the neurons in the brain are either GABAergic or glutamatergic. GABAergic represents the main inhibitory neurotransmission, and glutamatergic neurons represents the main excitatory neurotransmission. And we actually believe that there are more GABAergic cells in the brain, tightly regulating the firing pattern of the neurons. Epilepsy is believed to occur when, for some reason, hyperexcitability has occurred. For some reason, the GABA neurons are not able to regulate the firing of the glutamatergic neurons properly. And then this leads to the uncontrolled discharge. Now, in talking about the cerebral cortex, I just want to remind you that the cerebral cortex is the area or the tissue that covers and is the outermost layer of the cerebral hemispheres. These represent the part of the brain that would have developed last from an evolutionary point of view in humans, and it's very folded, representing a large surface area to volume ratio. Actually, it's folded so much that if you were to unfold the cerebral cortex, it would represent between 2.5 and 3 feet square. And you can just imagine that what would be required, what your head would have to look like, what your skull would have to look like if that folding did not take place. That folding allows 1/3 of your brain to be on the surface area, but it allows 2/3 of that surface to be folded and hidden within the grooves of the brain. Now, that outer layer of cortex that often gives rise to seizures is variable in thickness because of the folds, ranging in 1.5 to 4.5 millimeters. And that outer layer of cortex actually represents 40% of the total brain weight. And this is where a lot of processing and behavior is controlled from. Now, this outer layer of cortex has a very regular arrangement of 6 layers. I'm not going to go into that in great detail with you. You will study this in your other courses, in your anatomy courses. But I just want you to appreciate that these layers, layer 1, the molecular layer, layer 2, the external granular layer, layer 3, the external pyramidal layer, layer 4, layer 5, and layer 6, represent the fact that the cortex is very well organized. And that organization represents part of the system that the body uses to control and regulate firing. In other words, the neurons are not just thrown together in a haphazard manner. There's architecture which allows them to function correctly. Now, let's talk a little bit about the basics around epilepsy. It's one of the most common neurological disorders, and it's a chronic neurological disorder. As I said before, about 5% of persons, or 1 in 20 persons, can expect to have a seizure during their lifetime. Now, having a seizure does not mean you have epilepsy. The point prevalence, or the incidence of epilepsy in the population at any time is much lower than 1 in 20. It's 0.5 to 1%, or 1 in 100 to 0.5 in 100. Advances in drug treatments now means that the majority of persons, 78%, can be well controlled with the drugs available to us. However, unfortunately, there's still a sizable portion of persons who have intractable epilepsy, epilepsy that is resistant to drug treatments, and we still have not been able to work out how to fully manage these persons. What are the causes of epilepsy? Well, there are many causes of epilepsy, but it's important to appreciate that about 2/3 to 3/4 of all cases are unknown. That means we cannot identify a cause or trigger. What is the underlying mechanism that's giving rise to this spontaneous, synchronous discharge? Now, it's very, very important to appreciate that, because if we can't identify the underlying cause, that means we aren't able to cure the condition. We can only manage it through drugs. Fortunately, many of these persons who might develop epilepsy during childhood often grow out of it. The other reason why this is important is because if somebody does present with seizures and we suspect epilepsy, it's very important to do a thorough group of investigations to identifying the underlying causes, some of which are highlighted in this diagram. For example, a congenital defect, or a vascular disease, or a tumor, because these underlying causes in many cases might be treatable, and therefore not only do you get rid of the tumor, but you also manage to cure the epilepsy. As you saw in the little video, seizures can be defined or grouped into 2 ways. We talk about focal seizures and generalized seizures. Focal seizures occur in one part of the cortex. Generalized seizures involve wide areas of the brain. Focal seizures don't often result in a loss of consciousness, whereas generalized seizures do. The 2 cases that we just saw are examples of generalized seizures. The first is often called a grand mal seizure, with the tonic-clonic jerking pattern that I think most of us are familiar with when we say the term seizure or epilepsy. The second one is often called petit mal, and that involves the blanking out or staring and the association of loss of consciousness that occurs in what are called absence seizures. In terms of focal seizures, it's important to appreciate that the site of the discharge will determine the behavioral manifestation. So, for example, if the seizure occurs in the motor cortex, you're going to get motor symptoms with random jerking motions on the contralateral side. If it occurs in the visual cortex, you might see flashing lights, or the patient might report a visual aura. If it occurs in the somatosensory cortex, they might talk about sensations, feeling sensations on their bodies. And so depending on the site of the seizure, it tells you where the lesion or the origin is. Now, focal seizures are usually cortical in origin and tend to be limited to one particular region of the brain. Generalized seizures can start in one part of the cortex and spread to the rest of the cortex. But very often, they're subcortical in origin. And because many of the subcortical neurons project to wide areas of the cerebral cortex, having started there, it then spreads and leads to the generalized seizure. This table here is one that I'm not going to go through. There are many examples of this in your textbooks, and it now just gives you the classification of seizure disorders. into generalized seizures and partial seizures that we just spoke about. Now let's talk a little bit about the EEG. The EEG stands for the electroencephalogram, and it's a study or measure of the electrical activity associated with the firing of the neurons in the brain. The first person to really discover or study this was a German neuropsychiatrist, Hans Berger, who was able to make EEG recordings from a dog at the turn of the 20th century and in humans in 1920. When recording an EEG, what are we really doing? Well, as we've said repeatedly, EEGs are the electrical activity, and it's set up when an action potential fires or when there's synaptic transmission. For example, here there's a synapse and there's a release of a neurotransmitter that results in positive charge entering the cell. This positive charge entering the cell makes the outside of the cell relatively negative. And then the flow of the current here sets up a region here where it's relatively positive to maintain electrical neutrality. This electrocellular dipole can be measured and picked up by electrodes either placed on the surface of the skull or during surgery on the surface of the brain. Now, these signals will be very small, but if you have several neurons firing together at the same time, those signals can be added together. In other words, if you have synchronous activity, that's the word we use when we say neurons are firing together at the same time. In this first diagram on the top, these 6 neurons are not firing together at the same time. The activity is asynchronous, so you don't get a large signal. But when they do fire together at the same time, these signals could be added together, as can be seen in this diagram. And these signals are much better recorded and detected by our electrodes. And it's these signals that are able to form the basis of the EEG. As I just mentioned, EEG electrodes can be placed, primarily they're placed on the skull, but sometimes during surgery, they can actually be placed on the scalp or actually within the brain tissue. And in today's world, we primarily use EEGs in the conduct of understanding epilepsy, but they can be used for trying to understand other disorders. Now, one of the things we have to understand, or we want to make sense of, is in recording an EEG, where would we place the electrodes? Is this just done randomly all over the skull? Or is there a system that allows us to compare persons with one another? And if we want to make sense of the EEG, we want to be able to compare people and create what's a normal. So to do that, they've developed something called the International 10-20 system of placing electrodes, in which 20 electrodes are placed on the skull. Now, you can do EEGs with as many as 128 electrodes, but this 10-20 system is a standard battery that is used in many EEG labs. Now, to identify these locations, you have to measure or draw some lines on the skull. You don't actually draw these lines, but these are imaginary points. The first point runs from the nasion, which starts at the point between forehead and nose, and it runs to the back of your skull to a protuberance just above the neck called the inion. And what you do is you would measure that distance, and then you would calculate 10% at each point along that line. The second line we draw is between the preauricular points, which is where the maxilla and the mandible meet, right by the zygomatic arch in front of the tragus of the ear. And you draw a line connecting those preauricular points. And you also take 10%. And then with your 10%, you're able to draw circles around the skull. And these are where we're going to place our main electrodes, our 20 electrodes. Now, these electrodes then have a particular nomenclature, which allows us to understand what's going on. And we get a signal from each electrode. You can see that A1 and A2 are connected to the earlobe, and they represent the ground electrodes. You can also see in this diagram that those electrodes on the left are labeled with an odd number, while those electrodes on the right are labeled with an even number. And you'll also notice that the electrodes over the frontal lobe are given a prefix of F, those over the temporal lobe a prefix of T, those over the parietal P, and those of the occipital O, and those in the central area have a Z as their suffix, their indentation. What does this mean? Well, if I tell you that I have a recording or there's a lesion in T5, what I'm telling you, it's in the temporal lobe region of the brain and it's on the left side. If I say the problem is at O2, or look at the signal from O2, I'm telling you, look at the signal from the occipital lobe on the right side. And so this allows us to compare signals with one another and between patients. Now, when someone comes for an EEG, there are some routine things that we ask them to do. Often we'll ask them to record with their eyes open and then also with their eyes closed. We can also ask them to hyperventilate. And I want you to go and research what will happen to the EEG when a person hyperventilates. And then sometimes, depending on the lab and making sure we have the correct safety equipment, you can expose them to flashing lights, because some persons get epileptic seizures or their EEG becomes a little abnormal when they're exposed to this stimulation. Of course, note I said this has to be done with proper protocols. Other things that we can do is we can give people EEGs if they've been sleep deprived or if there's particular patterns of behavior that lead to seizure precipitation. Now, when you study sleep, you'll do this in a lot more detail. But there are some characteristic wave patterns that are associated with the EEG. And these are dependent upon the frequency of the wave and the amplitude of the wave. In order to determine the frequency of a wave, you must always have a time scale, because of course, frequency represents cycles per second. The slowest waves associated with the brain are the delta waves associated with slow wave sleep. They tend to be less than 4 cycles per second, less than 4 hertz. The waves associated with being awake are called beta waves, and they tend to be up to 30 hertz. And so you can determine what wave is occurring and what part of the brain it's coming from by looking at the frequency of the waves. And this is something you need to practice and be able to do. And so this here is just a sample EEG. And if I were to ask you what is happening here, you would tell me that you can see all 20 leads, but you would be able to notice that somewhere around here, something starts to happen. And because this is happening across all leads, and because it looks like large electrical activity, we could suggest that a generalized seizure is taking place, because it's not localized to one particular area of the brain. And it seems to represent an uncontrolled discharge in the brain. I just thought it would be good, because there are so many myths and misconceptions surrounding epilepsy, for you to see what is supposed to be required or what should be done if you see somebody having a seizure. And this video here was put out by the British Red Cross. So let's just look at this video.
I got loads of work for college and that. Nah, he wouldn't know any better. Besides, it has nothing to do with him.
Sid, it's all right, mate. It's okay. I know what to do. Right, just pop that under your head. There you go. Okay. I'm going to stay with you until it's over, okay? gonna roll you onto your side, mate, so you can sleep it off. That's it, I'm just gonna tilt your head back, mate. There you go, just keep it there for me. You're all right, Zed. It's okay, mate. I'm with you.
You realize, as I said, there are many myths and misconceptions associated with epilepsy. Often people say you should try to stop them biting their tongue, you should put them in their mouth, put something in their mouth. That usually makes things worse. And so you saw a video there just showing some very simple ways in which epilepsy should be managed, or not so much epilepsy, a seizure should be managed if you view one. Now, the EEG promised a lot of success, but generally in today's world, we don't use it clinically a lot unless we're dealing with epilepsy. It does have certain advantages because it is a measure of brain function, and it allows us to see direct evidence of problems with firing patterns. It does tell us to some extent where these firing problems might be. It gives us spatial localization. And generally, it's cheap, non-invasive, and doesn't cause any harm and readily repeatable. Some of the disadvantage is even though it can detect a dysfunction, it can't tell you what caused the dysfunction. And it's not a very sensitive tool. And that's why in the past, we've tried to use EEGs to diagnose other conditions, and it hasn't been that successful. It is a difficult test to perform at times, and it can be affected by the level of consciousness or drugs in a person's system. And then sometimes you might get nothing at all, even though the person does suffer with a seizure disorder. So as we come to an end, I do want to alert you to the fact that the vast advances in technology within the last 10 years have now taken us to understanding and utilizing brainwaves in a very different manner, in something called BCI, or brain-computer interface. And I just want you to look up a little bit about the BCI technologies emerging, because now we're not just using EEG in a clinical setting, but many persons out there are seeking to use the EEGs and harness them into taking the signals from the brain to do other things. Whether it's play video games, or whether it's for prosthetics, or whether it's for understanding what's going on in the human mind. And so as technology increases, the role of the EEG and the role of understanding these brainwaves is becoming more and more important. And so there we have it, just a brief introduction to what the EEG is, why it's important, how it is relevant for helping us to understand what's taking place in a seizure, and how if persons have multiple seizures, this may reflect that they're suffering with epilepsy, and what are just some of the common conditions associated with epilepsy. Until next time, take care and keep safe.